Well, hello. I'm Daniel Benjamin, and I have the pleasure of being the president of the American Academy in Berlin. And tonight, given the speaker and given the assembled guests, it's a particularly great pleasure. Tonight's talk is entitled Confronting the COVID-19 Pandemic, and it will be delivered by Dr. Howard Koh, or as I have addressed him following the very best German practice, Professor Dr. Honoris Causa Molt Howard Koh. This is a great evening for us at the American Academy because it marks the inauguration of the Bayer Fellowship in Health and Biotech. And with this new fellowship, the American Academy aims to make a worthy contribution in the absolutely critical field of health and biotech, critical fields of health and biotech. We aim to do this by supporting interdisciplinary dialogue with representatives from the academic, political, corporate, and public sectors. And each year, the Academy will bring one of America's foremost figures in health and biotech to Germany to meet with counterparts, experts, policymakers, and the like in order to deepen the dialogue. I want to take this opportunity to thank Bayer AG not only for generously sponsoring this fellowship and making tonight's event possible, but for its consistent and generous support of the Academy's work for almost 20 years now. And I particularly want to welcome from Bayer tonight the head of Bayer's Pharmaceutical Division, Stefan Ulrich, and Oliver Renner, the division's head of communications. It's really no overstatement to say that Bayer is making it possible for the Academy to really make a contribution in these most pressing areas facing our societies, including on the topic of tonight's presentation. So September 21st was a day that probably few noted as being anything special, though I believe it was the first day of fall. It was also the day that the number of fatalities from COVID-19 in the United States passed 675,000. Chances are that we passed the number much earlier because of the vagaries of attributing causes of death. But the number is significant because 675,000 is the number, also a questionable number, but the number that is generally given for U.S. fatalities due to the Spanish flu in 1918, 1919. Now, there are a million reasons why one should not compare these two pandemics, and I assume that none of the scientists in the room would venture this kind of folly. But in 1918, the U.S. had less than a third of the population that we have today, and so the percentage of deaths was obviously higher. And there were differences between these two viruses in terms of infectiousness, lethality, and other factors. But the reason I find this so interesting is that the era of the Spanish flu was on really the other side of history from us. It was before the advent of modern medicine, which I think most historians and scholars date from the introduction of penicillin in the 20s and 30s. So a true revolution separates us. I believe it was the English writer Muriel Spark or Iris Murdoch who used to say the past is another country. In this case, the past is another world. Life expectancy in that period hovered around 53. Today, it's close to 80 in the United States, that is. The innovations in medicine, as we know, have all been head-spinning. And that's not just in therapeutics, but also in prevention. Today, as we speak, there have been some 740,000 deaths in the United States. And just to add another fact, the U.S. has something like 16 or 17% of all global COVID deaths, to the best of our knowledge. And compare that with less than 1% in the era of the Spanish flu. That really tells you something about what has happened. And if you add to this picture the fact that we've witnessed in just the last 18 months a period of extraordinary medical innovation with the development of vaccines, which previously took years and only a matter of months, the whole situation becomes even more mind-boggling. And that extraordinary period of innovation has brought forward a new technology of vaccines. It's not just new vaccines, using messenger RNA, and those may have numerous positive applications for the future. So today's 750,000 deaths in the United States, and I'm really only speaking about the United States, I'm not going to make any judgments on other countries, suggests to me that even if we have made extraordinary leaps forward in science, we may have well moved backwards in terms of governance, public education, and social management in just the last century. And to my mind, that is extraordinarily painful to contemplate. That intersection of science and governance is the subject of tonight's talk by Dr. Koh, and who is the American Academy's inaugural Baer Fellow in Health and Biotech. Now, to introduce him, Howard Koh is the Harvey V. Feinberg Professor of the Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health and at the Harvard Kennedy School. At Harvard, he also chairs the Harvard Advanced Leadership Initiative and serves as the inaugural chair of the Harvard Chan School of Public Health Initiative on Health and Homelessness. He has earned board certification in no less than 4 medical fields, including internal medicine, hematology, medical oncology, and dermatology, as well as a Master of Public Health. From 2009 to 2014, Professor Koh served under President Obama as the Assistant Secretary for Health for the United States Department of Health and Human Services. And as Assistant Secretary, he oversaw 12 core public health offices, including the Office of the Surgeon General, the U.S. Public Health Service, 10 regional health offices, and 10 presidential and secretarial advisory committees. And by the way, we may list those advisory committees last, but since they are not government employees, but frequently academics from other institutions, that's why he has that little bit of gray hair. Howard Koh has served as Senior Public Health Advisor to the Department of Health and Human Services Secretary. He oversaw the Healthy People 2020, the nation's public health agenda. He promoted disease prevention, public health dimensions of the Affordable Care Act. He advanced outreach to enroll underserved and minority populations. He helped to coordinate federal response during the 2009 H1N1 pandemic, and was the primary architect of landmark HHS strategic plans for tobacco control, for dealing with health disparities, and for chronic hepatitis. Howard Koh has earned over 70 awards and honors, including 6 honorary doctorate degrees. He's published over 300 articles in the medical and public health literature. He has, an arm's length of other distinctions, and I would not be able to leave time for him to speak were I to recite them all. Howard Koh has dealt with myriad public health issues. We'll leave it to him to tell us whether he's faced any that were more challenging, more impactful, if you will, than COVID-19. It is really a great pleasure to give the mic to Professor Koh. Let me just first say, so that everyone at home understands what's going on, the people in the room, when we get to the Q&A, Dr. Koh will speak for 30, 40 minutes. We'll then have a Q&A. If you have questions here, just raise your hands. If you're on Zoom, I think that there will be a tablet that's handed to me. Yes, it's being confirmed as we speak. Type your questions into Q&A. Don't raise your hand. No one will see it. And with that, Dr. Koh, it's a great pleasure to welcome you to the American Academy.
Thank you so much, President Benjamin, for that very warm welcome. And what a great honor it is to be here in Germany, to be in front of this very distinguished audience, to serve as the inaugural Baer Fellow in Health and Tech at the American Academy in Berlin. In my week here, I've had an extraordinary outpouring of hospitality granted to me from Dan and his team, Barrett and Caitlin and Matthias and so many others. And then I've gotten to meet many of the public health and scientific leaders of Berlin and Germany and Europe already. So it's an incredible community. I feel so blessed to be here and so grateful to meet all of you. Let me also, before I officially start, give my thanks to Mr. Stefan Ulrich and Mr. Oliver Renner and Bayer for making this part of transatlantic understanding possible. It's a great mission in a very important time for our world, and so it is so wonderful to be here. I have the great privilege of giving you an overview of confronting the COVID-19 pandemic, and I'm sure you're all wondering, okay, how's this guy going to do this in 40 minutes, right? And let me just start off by saying we have a brilliant but highly diverse audience. Some of us are experts in health and science. Some of us are experts in law. Some of us are expert novelists, cartoonists, members of the press, business leaders. We have an incredibly diverse audience, but we need all of you in public health because this field is absolutely fascinating. It's drawn me in over my career as first a clinician and traditional physician before I got asked to serve first as Commissioner of Public Health in Massachusetts under 4 governors, by the way, and then later as Assistant Secretary for Health in the Obama administration. So what I'd like to do in my presentation is give you the broadest high-level overview, start with some comments about what's happened in the United States, move into the impact of the pandemic here in Germany and Europe, and then make some comments about how the pandemic has hit every country and every person around the world, and then efforts to try to build a better public health system so that we can get through this and hopefully be better prepared for the next one. So that's my goal. So let's start with the most basic question. I ask this to my students because they often come to our school, the Harvard Chan School of Public Health, and I ask them, how do you define health? And also, how do you define public health? And it's a fascinating exercise if you stop and think about it. Here are 2 statements from the World Health Organization that I think about almost every day, and they make me ponder the gift of health and then also ponder the future of public health for our world, especially at a time like this. The first is a definition from WHO that health is, quote, a state of complete physical, mental, and social well-being and not merely the absence of disease or infirmity, quote unquote. I love that definition. Oftentimes we think of health in an extremely narrow way, or we focus on one organ of the body, or we focus on absence of disease, but that's not what health is. Health is complete well-being, and that theme I hope I can keep referring to through this presentation, particularly as we think about the impact of COVID, not just on our physical health, but our mental and social well-being. And then the next line is also very inspirational for all of us, and it's carved into the granite of the exterior of the Harvard Chan School of Public Health in multiple languages, and this is, quote, the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, quote unquote. And I love that phrase too, because we all have this gift and potential of health, and when we reach that highest attainable standard, that's public health success, and it's something that we celebrate. But we cannot take it for granted because there's so many threats to our well-being day in and day out that we don't really think much about. And then we should get into, well, what is public health? Before COVID, I used to tell my students, you're entering a very important field. You're going to save a lot of lives. You probably won't make a lot of money. That's okay. But people don't really know what this field is. They haven't heard very much about it. Today, I say to the same students all the same things, but okay, everybody's heard the term, but they still aren't really quite sure what it is and what a good public health system is. So let me quickly tell you how I see what public health is and how it impacts every human being on this earth. Because what is public health? What's a day in public health? Well, a day goes as follows. You wake up in the morning and you open your eyes and the air is clean to breathe. That's public health. You get up and you turn on the faucet and the water is clean and often fluoridated. That's public health. You do your morning workout, it's good for the body and the soul, that's public health. You sit down for breakfast, you're dying for the donuts, but you have the wheat toast, that's public health. You get in your car, you put on your seatbelt, that's public health. On your way to work, you drop off your child or your grandchild at daycare. They need to be vaccinated to start. That's public health. You get to the workplace, it's tobacco-free and smoke-free. That's public health. At the workplace, you have an accident, and an ambulance comes and takes you at the right time to the right place. That's public health. And then the last line, relevant to tonight, is, and then unexpected threats come, and you expect the system to stand up and protect you so you can keep reaching your highest attainable standard. That's public health. So that's what the world is thinking about right now. And I would like to invite all of you, regardless of exactly your area of expertise, if we had to do this all over again, what kind of system would we need that would have prevented all this preventable suffering in Europe, in the United States, and indeed around the world? So as President Benjamin mentioned, I'm a physician trained in multiple fields, started my career as a clinician, but I was called into public health because early on I saw so many patients dying preventable deaths and suffering preventable suffering. And at the time, it frustrated me. At the time, I never had heard about public health or a public health school or service in a federal or state agency in public health. So over the years, I gravitated to that world and the whole area of disease prevention and therefore policy. And so I first served as the state health commissioner, as I mentioned, and then in the Obama administration. I just want to share one slide of photos that mean a lot to me personally, with a story behind each. I had the great privilege of serving as the Assistant Secretary for Health under Secretary Kathleen Sebelius, a tremendous public health leader. By the way, I was the Assistant Secretary for Health. They called me the ASH, for short. Everything in Washington is an acronym. And for one who spent much of my life to tobacco control, to be called the ASH, I found somewhat ironic. It was an incredible privilege to serve under a president who prioritized health care and the Affordable Care Act as his highest priority. And so under the president and Secretary Sebelius, now we can say 11 years later that some 23 million more Americans have received health insurance coverage than compared to back then. So that's something we all treasure. None of it was easy. I had the great privilege of meeting the then Vice President, now President Biden, who now is trying to lead the country and the world through a very difficult time. Had the extraordinary honor of working closely with Dr. Tony Fauci on the bottom left, who I view as a historic figure. His perseverance and dedication to science is pretty extraordinary. On the upper left, I had the incredible privilege of being on the U.S. delegation to the World Health Assembly in Geneva a number of times. So to sit behind the placard that says United States of America as a Korean American and as a son of immigrants is something that I deeply treasure. And I think whenever I do, I think of my parents' journey to the United States. They sacrificed so much to raise our family, and to be able to serve my country that way is something that I never take for granted. And then when you do public health in these state and federal positions, when flu vaccine are available, you're often asked to take a shot on camera. So here's another opportunity. This is the National Press Club in D.C. The first time I did this when I was a state health commissioner 20 years ago, I knew I had to say something special to the press, so I got my shot, and I turned to the camera and I said, "That's one small shot for a man. That's one giant leap for public health." See? Health communications where it's at. Okay, so Dan and I did not coordinate this. In his very succinct couple of minutes, he pointed on a lot of key points here. So let's just start with this broad overview. You can see on the top set of numbers that the U.S. has 4% of the world's population, but some 15 to 18% of the deaths and cases. Lots of discussion about why the U.S. leads the world in cumulative deaths from COVID-19, now approaching 750,000, as Dan mentioned. So there's a lot of attention to the U.S. in that way, but on the bottom set of numbers, you see that everyone's expecting the U.S. to be the leader in terms of vaccinating the world, in collaboration with WHO and an effort called COVAX that many of you have heard about. If you look over on the right, what's stunning is some 7 billion doses of vaccine have already been administered worldwide. So when you think that we had nothing beginning of last year, that is quite an achievement. but that's still only about a third of the population of the world fully vaccinated. The WHO vaccination target is some 70% by midway through next year. Very importantly, with respect to equity and disparities, only 3% of people in low-income countries have received at least one dose. And so the more we do this, we're going to be hearing more and more about what are our obligations to low and middle-income countries and how do we get vaccines up and out and administered so that we can protect everybody. And of course, this has never been done before. So you can just see immediately the historic nature of the threat and then what public health is trying to do as a global community. So right now in the bottom right, you'll see a very important number, so keep this in your mind. 57% of the U.S. has now been fully vaccinated, so that's tremendous at one point. But the big question is exactly how much more do we need so we can achieve a so-called herd immunity, and more on that in a second. So we're dealing with a coronavirus, and coronaviruses have been around since 1960, contributing to the common cold, for example. You probably all know that SARS in 2002 and 2003 was a coronavirus infection affecting mostly parts of Asia, but also Canada. That was about 1,000 deaths, which was very disturbing back then, but overwhelmed by the tremendous death numbers that we've just cited here for COVID-19. MERS happened in 2012, mostly in the Middle East, but also affected South Korea. These are historic points to note because I often think that, especially when the first cases were described last year, Asia had been through this drill before, and they were comfortable with using masks and being asked to wear that in all places. So when we get to today and some of the resistance that we're seeing and feeling, keep this in mind. And then, of course, in the era of Delta, we're always worried about new mutants and new strains. So just to refresh your memory, it was January of last year, 2020, that the first patients with coronavirus first described in Wuhan were identified in the U.S. Around the same time, the first cases were described in Europe. So let me just ask you the one audience participation slide, okay? If we had to roll the clock back to January of 2020 and say, okay, we have a new, novel, frightening coronavirus in many parts of the world, what kind of dimensions of a robust public health response is required to counter that and protect as many people as possible? So let me just pause and just yell out what are some of the themes that we need to have a really robust public health system to counter this threat and now the ones in the future that are certainly going to come. Okay, travel coordination between countries about travel, yeah, which is a very complex area right now. Yeah, global cooperation, good. Testing, yeah, we had no tests back then, right? And then every country started in. Some countries did this better than others. The U.S. got off to a slow start, unfortunately. So the testing is very important, and that also involves laboratories that are not just public laboratories, but also private laboratories, and how do public and private laboratories work together? Okay, other themes? Yeah, contact tracing and what we call non-pharmaceutical interventions. So contact tracing, isolation and quarantine, right? So you remember the first, almost all of last year, we had very little pharmaceutical capacity. What we had were the public health measures that the world had back in 1918, the time when Dan was describing. So those are so-called non-pharmaceutical interventions. Other things? Masks are still part of the non-pharmaceutical intervention, so that's all part of the same category. More? Information, excellent. Yeah, information, education, understanding the science, and the science was evolving all the time, right? So one of the challenges that public health authorities have had through this is, as the science evolves, they try their best to update the communication, but that really gets the public very frustrated. And then after a while, they get resistant. They say, oh, well, you guys keep changing your mind. But So it's true, we could all communicate better, but a lot of this is that the science was evolving, and so having good communicators, good communication programs is very important. Okay, other themes?
Hygiene.
Yep, hand hygiene, part of the non-pharmaceutical interventions theme. Maybe a couple more, just.
Sick leave.
What's that?
Sick leave.
Yeah, so, interacting with businesses and schools, because if you want some example of how public health has got to be the #1 priority, because if you don't have public health, you can't have businesses functioning, you can't have schools. And I know some of you had children who, missed a good part of last year. It's devastating to their well-being. So those are all the themes that we think about when we want a good public health system. Effectively communicating the science, good surveillance and testing, good data monitoring. Where do we get this data? Is it reliable? We need education, messaging, non-pharmaceutical interventions. Then over on the right, we need to support a public health workforce so that they have the energy and stamina to get through this. Some of these folks have been working 22 months, and the blowback they're getting is something that we're all concerned about, because the morale is very, very tough. These are not just public health professionals in the community, but healthcare workers in hospitals. Then the public health leaders have to coordinate with hospitals, because hospitals are trying to ramp up in what we call surge capacity. The pharmaceutical interventions is a huge success story, as Dan already mentioned, and we're going to say much more on vaccines. And then the global collaboration and cooperation. So those are very, very important themes. So let's just try to look at some of these and how they played out in the U.S., in Germany, and Europe, and then worldwide, as we try to look at how to improve these systems going forward. And through all of it, we need leadership. We need commitment from the top, with an attention to equity, so that all people can reach their highest attainable standard of health. So just one very simple slide about understanding the science, and just to take you back, when the first cases hit last January, the scientific assumption was that this was communicated through droplets only. And if you look over on the right, that means an infection where the particles are on the larger side, more than 5 microns, and they just fall to the ground within feet of you if you spread it through talking or breathing. But over time, it became clearer that airborne transmission was also a major part of it. And if you're not familiar with these terms, just think of walking into a room that's very well lit and there was cigarette smoke in there. You can see little particles floating through the air, and they stay there for minutes or even hours. So that's airborne transmission. People didn't really understand that initially, but now we do. And then another very important assumption that was updated through the science was, initially we thought that transmission only happened when you were symptomatic. But now the studies have shown definitively that asymptomatic transmission can occur even after vaccination through people with so-called breakthrough infections. So I could say much more about this, but I won't. But this evolution led to all these changes in mask guidance by the CDC in the U.S. and elsewhere, and that's caused a lot of frustration, because the recommendations changed as the science changed. And then we are really still wrestling with this question of herd immunity, which is defined as resistance to disease spread due to a high proportion of immunity from prior infection or vaccination. So if you look at the little graphic there on the left, there's no herd immunity. The infected figures are in red, and the figures in light blue have no immunity. And your goal is to get more and more people infected over on the right. And when you get to a certain level, you hopefully shut transmission off, and that's what herd immunity or community protection is all about. By the way, I hate the term herd immunity, because we're people, not cattle, but that's the scientific term used. So a big debate is, what level of do we need before herd immunity is achieved? For infections like measles, it's 95%. So if SARS-CoV-2 ends up being like measles, we got a long way to go from our 57% in the U.S., right? For polio, it's 80%. For COVID-19, we don't know. So that's part of the frustration scientifically and with the public, because people keep saying, okay, we need to keep vaccinating. How much more? And no one can really tell you. And that's just part of the uncertainty of a challenge like this. Okay, now let me show you the trends very quickly in the U.S. That's the top graph. And I show the Germany rates on the bottom just for comparison to see all the waves we've gone through since the beginning of last year. And it's, when you stop and think about what we've lived through, it's very sobering. In the United States, the president declared a national emergency in March of last year. And the president issued a 50-day non-mandatory stay-at-home order, which had uneven state implementation. And, you know, we have a federalist government in the U.S. like you do here in Germany. So each state could decide for themselves about how aggressive to be with not only these efforts, but other non-pharmaceutical interventions. I must say, as last year unfolded and we watched states sometimes competing against each other for PPE and ventilators, it was very difficult and raised lots of questions about, in a time of crisis, what do we do as one nation, whether it's the U.S. or Germany or other, and how much do we leave up to the states, whether it's in the U.S. and Germany or other places. And then we went through a very difficult period where the president was adding to scientific misinformation here, suggesting injecting bleach. He then confirms that he's taking hydroxychloroquine, which is an anti-malarial treatment, has been proven not effective for either treating or preventing COVID. You remember that last October he got quite ill, was hospitalized at Walter Reed, got monoclonal antibodies, which at the time weren't even FDA authorized, recovered. December, everyone breathed a sigh of relief. I'll be saying more about vaccines because vaccines were finally here, and the anticipation was extraordinary, and the stress on the public health system was even higher than before. Then President Biden was inaugurated in January, and the big wave of vaccination, the peak was, I think, 3 million a day. Right now, it's about 1 million doses a day. And the trends were going down. You're looking at the top trend, right, compared to Germany on the bottom. And lots of hope that by summer of this year that we'd be through this and back to some sense of, quote unquote, normalcy. But then Delta kicked in, exceeded half of the new cases by July, and has kept on going. Meanwhile, we've had several vaccines authorized. Now Pfizer's fully approved as of August, and then boosters were just authorized for 3 vaccines in the U.S. So that was the story. And then if you're following the news, just yesterday, the CDC is now recommending vaccines for kids under 12 from 5 to 11. So it's been quite a story just to see the vaccine rollout, the groups prioritized, and how we try to offer public health protections to everybody in a time of crisis. Now, what's key in understanding the suffering here is that COVID-19 is a fast pandemic that's actually fueled by a long-standing, slower pandemic of preventable conditions, because we now know, and you've heard this probably many times in the news, that if you have preconditions like asthma or hypertension or obesity or diabetes or kidney disease or a combination, your risk of COVID hospitalization and death goes up. So we have multiple public health crises going on here. It's just that COVID has exposed the vulnerabilities in a very dramatic way. This has also led to some of the inequities that we're seeing in terms of outcomes in countries like the United States. So as we try to fix all this, we also have to pay attention to the underlying conditions that made all this possible in the first place. Somebody mentioned the importance of testing, and we don't need to spend a lot of time here. Just to remind you that there are 2 categories of the so-called PCR and now the rapid testing. And now, as flu season is about to come, and when people get mild symptoms, they're going to want to know, do I have flu? Do I have mild COVID? What do I have? So the importance of rapid testing, even though it's less sensitive, is growing. We've had almost 700 million tests done in the U.S. That number is probably going to keep growing. I know here in Europe and Germany, you've had a lot of attention to this too. And then you have to not forget the impact on hospitals and health systems, because in our country, hospitals are generally working around 90% capacity even before a pandemic, and then this threat hits, and people look to hospitals and doctors and nurses to take care of them, but you run out of beds, you run out of ventilators, you run out of PPE, ambulances may have to be diverted, surgeries may be canceled, and then if you see some of these headlines, about crowded hospitals and no place for patients to go. It's absolutely terrifying. One theme that came through in the news through COVID, which just stunned me as a public health professional, was the hospitals were implementing what's called crisis standards of care. In short, rationing. It's a terrifying concept, and most of you, if you stop and think about it, will be outraged that you had a family member who was very ill, needed to go into an ICU, needed a ventilator, and some hospital staff would say, you know, we can't do this for everybody. We're going to take the 5 of you who need it and pick one who's most in need and most likely to benefit and give the rest of you comfort care. I mean, that makes everybody outraged and angry, but that's where we are with this pandemic. It's stressed the system so much in the United States. And then, again, Dan referred to this. It's not surprising that deaths went up in the United States by over 20%, but COVID represented not all of it, most of it, 3/4 of it. But there are other excess deaths related to people with heart disease and Alzheimer's and diabetes who perhaps sought care less frequently or didn't want to come to the hospital at all. So if you add it all up, it's just causing more and more chaos from deaths from COVID. I got to write a little opinion piece about that in JAMA at the end of the year. And then over on the right, again, Dan and I coordinated well because he was talking about life expectancy. I mean, we all assume that generation in and generation out, the next generation is going to live longer, right? That's what public health progress is. But we now have data that from last year, life expectancy went down, and pretty dramatically by race. So for white females and white males, it went down a little over a year. But for black females and black men and Hispanic females and males, it went up as high as a drop of 3.7 years. So, you know, for the gift of health to be taken away so dramatically, and especially for communities of color, I mean, that's very, very upsetting for anybody who cares about public health. So, Dan, I keep teasing you. I mean, this slide comes from your comments. So when the COVID death toll surpassed the 1918 pandemic deaths, I got interviewed for this article like so many other health experts, and people said, oh, why do you think this happened? And I know that last year when the first cases were being announced, I mean, a lot of us got asked by the press, how many deaths are we going to have? What are your projections? And we turned to the modelers and the epidemiologists. I'm not sure how many people predicted that we would exceed the number of deaths that we had a century ago. And over a century, we've paid a lot of attention to healthcare, to hospitals, to doctors, to ICUs, to ventilators, to good medications, all excellent investments. But we've invested relative pennies into public health, in my view. And I think that's why we are having some of the challenges we're facing right now. So right now we have just about 100% Delta in our country. As you can see here, we've had several waves of the pandemic from the so-called wild type to the Alpha variant and now Delta. We're all watching very carefully as a new Delta Plus variant has been described, particularly in the UK. That might be even more transmissible than Delta. We sure hope not. So far, all the vaccines work against the variants, so this is another reason to accelerate vaccination as much as possible. And then here's a slide which is a tremendous credit to the pharmaceutical industry and to scientific innovation, because if you see from the top line, when people were looking for pharmaceutical interventions to confront COVID-19, everybody was concerned that in the history of vaccine development, the fastest vaccine was mumps, previously made in 4 years. And people are saying, can we wait 4 years for vaccine development? So to have multiple vaccines up and out in less than a year has been a tremendous advance in terms of the scientific community. So you see the multiple vaccines here that are recommended by the WHO, Pfizer, BioNTech, or as I say in Germany, BioNTech, Pfizer, mRNA vaccine, or Moderna, Johnson & Johnson, and AstraZeneca, which are so-called adenovirus vector vaccines. A couple made in China. This does not include other vaccines like the Sputnik one in Russia, which is not recommended by WHO. So there's been an approval process through the FDA in the US that you've all followed with recommendations by the CDC. And here is the main point of all this. These are not just good vaccines. These are great vaccines. Because look at the bottom line. Regardless of which of these you get, the chance of this keeping you out of hospitalization or death is extremely high, well over 99%. So that is something we should celebrate. And now with boosters, even though there's waning immunity and perhaps some increased risk for breakthrough infections, if we stay on top of all this, hopefully we can keep the hospitalization and death numbers down. And if you're not sure that these are excellent vaccines for preventing death, look at this slide. I love this slide. So this is the deaths in the U.S. by age. You all know that the higher the age, the risk is higher, which is why, for example, people in nursing homes were at the highest risk in the U.S. and everywhere else. After vaccinations began, deaths dropped dramatically. There's been a little bump there through Delta, but it just shows that these are really excellent vaccines, and we want to support the pharmaceutical industry as they keep pushing this innovation to do life-saving work. Now, the challenge right now in the U.S. and everywhere is the vaccine hesitancy. And if you look over on the left, these are serial polls done by the Kaiser Family Foundation that's tracking who's gotten vaccines, who wants to wait and see, and then who in the green saying, I will take it only if required or definitely not. The good news in the red is the definitely not or only if required numbers have dropped from about 24% total to about, 15, 16% total. But it's still over 60 million eligible Americans that have not been vaccinated. Lots of concern about whether communities of color that have traditionally been under-vaccinated are getting the vaccines they need and deserve. And there is some promising results in that area. But there's now even more attention in the U.S. particularly, but everywhere, about the political divide. And you're starting to see graphs like this on the right, where if you see the states in pink that had a larger vote for President Trump in last election, they have much higher unvaccinated rates than the states in blue on the left that went for President Biden. So this whole challenge with the political divide in terms of reaching people is a very disturbing one in the U.S. and many places else. And now we're in a time where mandates are front and center. I'll be saying more about this here, and I'm sure you're discussing this here in Europe. But just to remind everybody, and I'm glad there are lawyers in the audience, because they will tell you that since 1905, there have been Supreme Court cases that upheld the authority of states to enforce compulsory vaccination laws in a time of a public health emergency. Okay, so that's nothing new. There is legal support for it, and there's also court cases to uphold the authority of schools to exclude unvaccinated students from attending for students attending classes. You know, in the U.S. now, many students in many schools are mandated to be vaccinated before starting school. And so that is the backdrop. But right now in the era of COVID, there's a lot of resistance to the themes of mandate, even though there's ample history that supports these efforts. So in September of this year, after months and months of encouraging and enticing and cajoling people, the president decided that he was going to come out and make a number of announcements about requirements and mandates, particularly this one that's gotten so much attention that employers with over 100 employees had to have their workers vaccinated or tested weekly. So this is about to be implemented through the Department of Labor through what's called OSHA. And then when you do polls over on the right, whether you support this or not, there's a lot of division about whether this is the right way to go. So in the midst of all this, it's easy to forget all the other public health themes that are affecting people in the United States. The seasonal flu, by the way, don't forget to get your flu shot. We don't want a twindemic. All the delays in non-COVID treatment or screening, like I already showed you, that's causing decreased life expectancy. The challenges for emotional well-being are through the roof. Increased mental health challenges and substance use disorders. Opioid deaths have gone up, which is very tough. Obesity rates are increasing because this is something that we need to track as it's a risk factor for hospitalization and death, as I noted. The tobacco issue continues on in our country and indeed around the world. And oh, by the way, climate change over on the right, and you know that right now COP26 is going on in Glasgow. So are we going to revitalize public health in the United States in the midst of all this? Do we have a chance to do this? There have been some money through the American Rescue Plan. The president has proposed a pandemic preparedness infusion of funds, but there's a lot of anticipation about the ongoing discussions in Washington about infrastructure and budget reconciliation. When it's all said and done, will we have the funds and the resources and the political will to rebuild public health in a time of need? That's the question before all of us. So let's now shift over to Germany. So look at the lower numbers there, and I'm just going to walk you through just very quickly some of the milestones that you're all very familiar with. They may sound familiar. A federal and state contact ban declared in March of last year, so social distancing. States tried to do some efforts there and then began reopening, but that was uneven, very much like the U.S. If you look at the numbers of cases in Germany for those opening months, it was really impressive, very, very impressive. So you're thinking, boy, okay, non-pharmaceutical interventions work. And, you know, we actually in the United States, we're all watching Germany with great envy because the numbers were so low. But people started to protest the restrictions. I mean, this is a global phenomenon. And then the rate started to go up. The federal government here introduced first a lockdown light, and then a more strict lockdown. And then the Pfizer vaccine was deployed starting, Pfizer-BioNTech was starting to be deployed around December of last year, around the same time as in the U.S. And then vaccinations, which were slow at the beginning, began to be open to all. Delta, again, started to comprise more than half of the cases now, the vast majority of cases here in this country. You here have had the 3G or the 2G rule implemented. Lots of attention to that. You have now fully vaccinated rates that are about 9 or 10 points higher than in the U.S. And I'm going to show you those numbers in just a second. And then, of course, you've had these very important elections just about a month ago. Now, what is humbling, if I can say, is that I pride myself in being up to date. I finished this presentation with my wonderful deputy last week and got on a plane, and then I rechecked the Germany numbers in anticipation of tonight. So please look at the paper right here and just look at where we've been in the last week or two, the last 10 days, okay? And so those incidence rises are quite disturbing. And we got to watch that carefully. In the U.S., they're declining, but here in Germany, they're going up. And is that mostly from unvaccinated people? Is it a combination of that and breakthrough infections and those fully vaccinated? Is it children? What's Germany and Europe and the global community going to do about this? We have to track this very, very carefully over time. So now we have here in Germany about a 65% fully vaccination rate, so that's 8-9% higher than the U.S. But again, some variation by state, as you can see over on the left, because you have a federalist style of government as we do in the U.S. And then some milestones over on the right that you're very familiar with, including the 3G rule. I'm trying my German here. Geimpft, genesen, getestet. How did I do? Pretty good? Thank you. But what is disturbing for our two countries, and in fact every society right now, is we have a major challenge with communication and misinformation, regardless of where we are. And we can discuss a lot about why that's the case. The WHO has declared an infodemic of misinformation. There have been studies like from Cornell University that showed that, unfortunately and tragically and sadly, President Trump was a large driver of misinformation in the U.S. Over on the right, you see Phil Valentine, who is one of 5 conservative talk show hosts who are anti-vaccination who have now passed away from COVID. And so when you think of the loss of human talent because they resisted this information, it's so tragic. And then we have entertainers who, who go on their Twitter page and send out information questioning the importance of vaccination to all their millions of followers, and of course Facebook, social media driving a lot of this. So lots of concern about what social media is doing to add to vaccine resistance now, and a lot of these themes affect issues of public health here in Germany as well. So here we are now in a time of confusing and often frustrating COVID restrictions, mandates, concerns about freedom. Every public health group in the country is wrestling with this and how to regain trust for a public that's pretty exhausted. And can we do this better next time? Can we communicate the importance of prevention better next time? Can we get more cooperation from the public, regardless of where we live, next time? Can we get through it this time? These are all questions for us going forward. So as I move on, here we are in Europe in terms of new daily COVID cases, some comments to make. So we see how the UK, Germany, Eastern Europe, and Russia are highlighted here. So we have some places in Europe like Portugal that has a very high vaccination rate, some 86% fully vaccinated. Over on the other end, Bosnia-Herzegovina, only about 15%. There's a typo there. It's the lowest in Europe, not the EU in Europe. Italy, that was very hard hit initially, is now doing very well and has come back very strongly. France got a lot of attention by requiring their immunity passport in public settings. Denmark lifted all the restrictions in September, so it's just to the north of us. And then when you take a global look, I mean, you could look at any country in society and make these fascinating observations about what's going on. So let's start at the top right and go around. Russia, now going through a terrible problem with the highest cases ever recorded there. China, where this started, is doing better. They've had a very aggressive, many would say draconian, implementation of public health measures that still pursues a so-called zero COVID policy. New Zealand Prime Minister Ardern has gotten a lot of attention for her aggressive public health measures there. India had tremendous challenges at first, but is bouncing back, has administered 1 billion doses, so we're watching them carefully. Africa has been largely spared for multiple reasons, but South Africa is getting hit. Some people say that's because of their higher median age or complications of HIV and TB. We look to Israel a lot because they've been doing some pioneering work on boosters and vaccinations, and their tracking of their outcomes in terms of data and surveillance are very strong. It's absolutely tragic to see what's happening in Brazil, which has the second highest numbers of cumulative death in the world after the U.S., some 600,000 deaths. A lot of criticism of President Bolsonaro's leadership or lack of leadership there. And then you see Canada with a very high percentage of the population fully vaccinated. So in each of these areas, you can see a theme here. With respect to the most developed countries, the G7 countries, you can see the U.S. actually ranks at the bottom of the G7. Germany is doing a little bit better, but Canada and now Italy seem to be doing the best in terms of full vaccination rates. And the big question is, how do we get these numbers up even more? But just as important and just as pressing is the fact that vaccinations, of course, are doing much better in developed countries, which are in green, as opposed to the low-income countries, which are in the light brown over mostly on the left. Look at the UAE on the right, where the vaccine rates are just astronomically high, and their COVID rates are very, very low. So with each of these, there's a story to tell. But if we care about the whole global community, we have to make sure these rates go up for all countries, regardless of their income and background. And if we don't address this, we put ourselves at risk. This is not just the right thing to do, but if we leave big parts of the world unvaccinated for whatever reason, we risk more mutations arising and more threats coming back everywhere. So we have to do this as one global community as best as we can. Here's another way to look at the disparities and inequities. Look where Canada, places like Canada or China, where they have a very aggressive effort. Western Europe are doing well in South America. We were talking at dinner how well Chile and Uruguay are doing in the UAE. But places like Africa, the uptake is almost nil, and we just cannot ignore that if we care about global health in general. So my last number of slides, what do we do about this in terms of a global community? A new effort has started up through COVID called COVAX. Hopefully all of you have heard about this, an effort to have innovative and equitable access to vaccines worldwide. It brings together Gavi, a Vaccine Alliance, the WHO, World Health Organization, a relatively new organization called CEPI, the Coalition for Epidemic Preparedness Innovations, and some very laudable goals announced with COVAX, hoping to get some 2 billion vaccine doses available to particularly low and middle income countries by the end of 2021. But as time has gone on, there's been more criticism and frustration, and I have a range of reactions when I read those articles, because to do what COVAX is trying to do is absolutely historic, is absolutely Herculean, has never been done before. You can imagine trying to buy up and coordinate vaccines from high-income countries like the U.S. and others and try to distribute it to low-income countries and have it all go smoothly. There's been lots and lots of challenges. So do you think this is the glass half full, the glass half empty? We all agree it's got to improve and get better if we're going to have coverage for the whole world sooner rather than later. And in fact, if you stop and think about what's involved in a vaccine rollout from the societal point of view, there are issues of affordability, availability, acceptability, particularly in a time of disinformation and resistance, accessibility, working with global groups and COVAX and make it all go smoothly has been very challenging. Some discussion about waiving intellectual property rights. We can have a debate about that if you want. And then over all the way on the right, I don't know how many of you have ever tried to set up a vaccine site. I have many times. It's absolutely fascinating, because how do you take a gym or a stadium or a hall like this and turn this into a public health vaccine site? You need attention to supply, space, staff, safety, storage, and have the throughput go efficiently so you can reach as many people as possible. And that alone is a huge challenge in terms of building a good system. So a lot of attention now is focused on the World Health Organization to try to fix this. You hear about WHO almost every day, led by Dr. Tedros, who we all admire. But if you look at how WHO is set up, the World Health Organization, it's very underfunded. The budget is some $5.8 billion. That's over 2 years, by the way. So with this tiny budget, they're trying to take care of all the health issues of the world, not just COVID, but all the public health issues of the world. The dues mostly come from voluntary contributions, and their enforcement is really around what we call soft law, guidelines, codes, and recommendations, no power of sanctions. What complicated all of this, of course, was last year when President Trump announced that he wanted to withdraw from WHO. That was fortunately reversed on President Biden's first day, but there's still lots of issues about working with WHO and CEPI and COVAX to have a true global effort. Over on the right, what WHO is proud of is a framework convention on tobacco control. As a tobacco control professional, I've followed this very, very closely. So that is a public health global success. And lots of people are saying, oh, we need a framework convention on COVID like we do for tobacco. What we have right now are so-called international health regulations that were updated in 2005, but have been found to be very wanting through this pandemic for many, many reasons. And so the international health regulations are supposed to coordinate responses to pandemic threats like this, but there have been so many questions about whether a global organization like WHO can move in areas where they don't have agreement from the states. Just look at the example of the fact that the first WHO delegation to China to investigate the origins of the outbreak did not happen until 8 months after the first case, and that was because of a lot of back and forth and negotiations about whether they were allowed in or not. And then it also took 30 days for them to declare what's called a FEIC, a public health emergency of international concern, that's been applied to other threats like Zika and Ebola and H1N1, which I worked on in 2009, it took them 30 days from the first case to announce a FEIC. In hindsight, a lot of people said that was way too late. We got to make sure this does not happen again. So all this is coming forward in front of a special World Health Assembly special session at the end of this month, November 29th. A lot of debate about whether the focus should be on a treaty, a new treaty like Framework Convention, or fixing the international health regulations at this point, and a lot of concern and attention to whether a new UN Global Health Threats Council should be formed, led by heads of state, not just health ministers. As the public health lawyers debate this, I defer to the best international public health lawyer I know, my brother, Harold Coe. And he said we really should try to avoid a treaty versus no treaty discussion. We should fix the leaky boat, the international health amendments, regulation amendments, while we can, because we can do that hopefully more quickly than create a new treaty, which could take 4 to 6 years. So his one-line summary of this in terms of strategy is try to fix the leaky boat while you build a better boat. And we shouldn't be fighting about this as we go into this session at the end of November and beyond. So something for us to consider as we watch how the WHO deals with all these issues. So my last couple slides come from this very important little article that came out in JAMA just last month, co-authored by Secretary Blinken from the State Department, someone that President Benjamin knows very, very well, and Secretary Becerra, another new secretary from my old department, Health and Human Services. How do we fix this? How do we build a better, stronger public health system worldwide? We modernize and empower global public health institutions like WHO. We assure that rapid identification and response happens faster. We try to strengthen international laws and norms. We're all waiting to see what the World Trade Organization will do in terms of this question of waiver of intellectual property rights. We have to improve financing for all this and make it sustained and not just voluntary, because we have left our global public health professionals high and dry, in my view, because they just have not had the resources to do what they need to do. Strengthen global governance with an emphasis on transparency and accountability, and then embed equity so we don't have places in the world where almost no one is getting vaccines, like in Africa, while other countries are flooded with vaccines and many people are getting boosters. Nothing wrong with boosters, but that disparity, if you will, can be troubling to many. So if you put it all together, we hope that with the involvement of all of you, all the professionals here in Europe, in the US, around the world, have an interdisciplinary approach to this, really respect and build and revitalize public health in our countries and worldwide. And hopefully if we do, we can really help more people enjoy the highest attainable standard of health. Thank you very much.
Well, thank you very much for a pandemic soup to nuts. That was really a remarkable overview.
Thank you.
So we have an unusually learned crowd here tonight, so I'm not going to embarrass myself by asking too many questions, but one question, I'm looking far out over the horizon. So in 2013 and 2014, when the United States was dealing with Ebola in West Africa, I think it was the National Security Council staff wrote a memo about what needed to be done to deal with the inevitable epidemics of the future and pandemics. And it clearly spelled out that there would be more in our future. If we look backward, we had SARS, we had MERS, we've had some serious flu epidemics, but we basically had nothing quite as bad since the Spanish flu. Are we looking at more on the scale of COVID, half COVID, a third COVID, 2 COVID in the future? And how do we know?
So that's a very important question, Dan. And that, I've lived this now for 20 years because I was the sitting health commissioner in Massachusetts now 20 years ago, which I can't believe, through 9/11 and anthrax. I'm not sure I even mentioned that. So that was my introduction to emergency preparedness and the threat of bioterrorism back then for the U.S. And what I learned, and so many of us learned back then, is you do public health and focus on certain priorities day in and day out, but then suddenly these threats come out of what appear to be nowhere, and you have to be prepared for those too if you're going to do your job. And we often don't like to think about these events that are terrifying and hard to predict, and quite honestly, sometimes low incidence, because we're so overwhelmed trying to do our work day in and day out. So if you look back at certainly public health in the United States over the last 20 years, when you have 9/11 and anthrax, or if you have H1N1, or if you have Ebola, what have you, there's always infusion of money from Congress, lots of pronouncements that we're going to build public health and make it stronger and be prepared. But over time, with budget crises and other threats, policymakers and budget officials often say, "Oh, nothing's really happening here. You're putting in all this money to be prepared, so we're going to take some of the money here and take some of the money there." And so attention drops, and then the next thing happens. So you're right. The example you mentioned was, there was a plan that was created by the National Security Council, and every administration should be taking that seriously and going through the drills and exercises and investing in the resources and the personnel. We just didn't do that. We just didn't do that, and here we are. So this is very difficult, but we need visionary leaders who say, okay, in order to do public health well and help everybody reach their highest attainable standard of health, we got to do the work day in and day out, but also be ready for these other potential threats. And that's what the nature of our field is right now.
I once, in my previous life as a university administrator, had dinner with a benefactor of my university who was the CEO of one of the world's largest corporations. And apparently in that corporation, they have a culture in which they would always say, "What's the one thing that you would do?" Yeah. And I found his question to be so annoying that I swore I would never invoke it again. But here I am invoking it. What's the one, if you had to set priorities for preparing for the next pandemic, what's the one thing? And just saying lots of money for public health will not do it.
I would love to have a society where every person, whether they have any kind of health background or not, says, what we need as our highest priority is the strongest public health system possible, where we respect the workers, where we support the workers, where we train the workers, where we have money for the systems, we have money for better labs and testing and communication and surveillance, so that when we need the system to work, in the case of a sudden threat, it works and it saves lives. We have not had that. We have not had that in the U.S. Germany is doing right now better in terms of vaccines. And particularly at the beginning, they did extremely well with non-pharmaceutical interventions. But over time, no country has done that well if you start looking around the world. So, I'm in this field because I started off as a clinician hoping to cure everybody. And I saw as a young physician that wasn't going to necessarily work because so many people were dying of preventable illness. That's what we're seeing on the large scale now. So it's a priority setting. In the debates in Washington right now about how we spend our money, I would love every leader to get up and say, okay, we're going through this terrible crisis. Our first priority is to rebuild this system so this does not happen again. I don't know about you, but I'm not hearing that. We're hearing about many other very important issues, but we're not hearing that. So we'll have to see how all these debates play out, and then Dan, we got to get through this, and then we just got to make sure we don't go through it again. Otherwise, the next generation, or sooner, is going to be facing all this all over again.
So what is the flaw, if you will, in our political economy that so many other voices are heard, but the voice for improved public health surveillance, public health response doesn't happen? I mean, there was a time, when people said that the American Medical Association was the most powerful lobby in the country. Mm-hmm. We certainly don't seem to be there now.
Yeah. Part of the challenge is talking about disease prevention sounds kind of boring It's not very exciting. It's more exciting to give a sick person a drug and cure them, and everyone's delighted. But if you protect somebody's health, people don't really respect that as much until that opportunity is lost. I have said now to many reporters who want to hear, when you lose a loved one, that's a tragedy. But when you lose a loved one and you know that death could have been prevented, that tragedy haunts you forever. And can I tell you, Dan, I have lived through that time and again as a clinician and as a member of society. And when you lose a loved one or a person you care about and you know that death had been prevented, you say, okay, how do we make this better the next time so it doesn't happen? So, I often think that since I started in my career as a cancer doctor in my 20s and I saw life being forfeited when people did not have to lose their life, that's what drew me into prevention and public health. And now the whole world is going through it. And it's very difficult to watch. So I'm hoping this crisis will be an opportunity where people respect the power of prevention in a more personal way.
It is interesting that we haven't seen more mobilization from families that had preventable deaths.
Yep, you said it, yep. Yeah, and I've been through this now, particularly with tobacco control, which has been a struggle too, but we've made progress, in HIV, all the other issues I mentioned.
When I misspoke when I said we hadn't had a major one since 1918, because HIV certainly qualifies.
Yeah. Sure, yeah. But look at the progress that's been made there because of great science, and that's where Dr. Fauci has been an unbelievable hero, if I can say. So, we need all parts of the system to work together. It's got to be interdisciplinary. It's got to involve everybody. And then hopefully if we do, everybody appreciates the gift of health, and everybody celebrates when the highest attainable standard of health is achieved for any individual or any population or any country.
Okay, well, I reserve the right to embarrass myself with future questions, but why don't we open it up to the audience? Why don't we start right here? Please wait for the microphone. Well, one then the other. You won't have to walk far then.
Thank you so much, Professor Crow, for your presentation. My name is Elizabeth Masuta. I'm from Doctors Without Borders, based here in Berlin.
Thank you.
And I have 3 questions. Maybe I'll ask 2. We've talked about pandemic preparedness, and now there's a lot of talk about financing and the prevention. And there's a talk about the fund of funds, which is going to be, which is an idea that's being debated at the moment, an investment of 10 billion a year. And it's supposed to be set up with the World Bank. And I'm just want to hear your perspective on it, because the World Bank is classically a development bank and not, an institution that's known for public health. So pandemics threaten countries like Germany as well, and we don't have so much to do with the development bank usually. So I would like to hear your thoughts on that. And then secondly, you've talked about the slow vaccinations, and I would say the disgustingly unequal distribution of vaccines around the world. And I would like to hear your thoughts on how that slowness or that inequality might affect the acceptability and vaccine skepticism in low and middle income countries.
Right. Okay. Excellent questions. So for the first one, if you need any evidence that public health belongs to everybody, not just health experts, this is it, right? I mean, every businessman who's had their business devastated, every school leader who's had their school closed, every parent that's had their kids suffer through this for all kinds of reasons can see that, unless we have strong public health, we're all at risk to have all these other sectors of society be disrupted. Now, it's interesting you mentioned the World Bank, because the former president is my good friend, Dr. Jim Kim, fellow Korean-American, by the way. So when he got appointed, everybody was saying, okay, why is this doctor being head of the World Bank? But I must say, he brought the sectors together and said, okay, this is supposedly just a financing, not just a financing organization, but there are broader dimensions here. So I think that having an organization like World Bank taking a look at this is absolutely appropriate. We need the interdisciplinary commitment from leaders of all parts of society. So that's very important. Your second question having to do with vaccine acceptance in places where the rollout's been very, very slow is absolutely key. I sometimes wonder, how do we make public health work when what used to be new and extraordinary becomes ordinary? So, back in the old day, putting on a seatbelt was extraordinary. Now it's ordinary. No one ever thinks about it. You do that, okay? If you teach your kids how to ride a bike, it used to be back in the day, no one had to wear a bike helmet. Now, in our country anyway, kids have to wear a bike helmet. You don't think what's extraordinary has become ordinary, and that's become normal. How come this room is smoke-free and tobacco-free, whereas a generation ago everybody would be smoking? Well, we changed what was considered normal. No one would come in here smoking. We changed the norm. So can we get a day soon where getting the COVID vaccine is just a normal, ordinary thing? It's not extraordinary. But right now we're in that window where it's extraordinary, and we're having all this uproar. So I'm hoping we can keep working through this and move through it so that sooner rather than later, everywhere around the world is viewing this as a very routine, ordinary thing to do. If there's a time where taking COVID vaccine is something that no one really thinks much about, that will have been public health success, right?
Just as a point of reference, what was the level of opposition to the polio vaccine? Or any of the other, major vaccine campaigns?
So traditionally, there's always some level of resistance to new vaccines. So if you remember in 2018 and 2019, in our country, there were measles outbreaks. And so, when mandates get discussed for anything, particularly vaccines, there's always concern about uproar. So I know everybody in the public health community knew that some level of resistance would happen to the COVID vaccine mandates. To have it at this level, though, is, I think, what is surprising. I think the disinformation is feeding a lot of this. For people who say, I don't like mandates and I don't like government telling me what to do, my reply is, this is the worst pandemic we've had in a century. What are you going to do about that? What's your contribution, So, yeah, no one likes mandates, and then also we've spent many months trying other methods, and we've only got to a certain level. So if we don't get closer to whatever herd immunity is, how much longer are we going to have to endure this? So this is where, in my view, every person's got to step up and contribute. President Biden calls this a patriotic thing to do. I think that's a right way to phrase it.
You had a question.
Thanks for a lovely talk, Professor Coe. So as an evolutionary epidemiologist, I completely agree with you that every case is a source of anxiety because we're rolling the dice on new variants that are more virulent, that are more transmissible, that escape immunity.
Right.
And I also agree with my colleague from MSF that there is therefore a pragmatic case to be vaccinating the world. There's also an ethical case, and I think that low number of cases in Africa that we see is actually probably reflecting more weak surveillance systems than anything else.
Okay, that's probably true. Yep.
But there's an urgency here as well, right? And I wondered whether we should be waiting for the World Health Organization, or whether doses that are going to waste because they're expiring, whether we shouldn't be thinking about rapid mechanisms to get them out sooner.
Right.
I'm going to allow myself 2 questions as well. Because and so my second question actually relates to something that Daniel Benjamin broke up, which was what would you spend the money on? And I think I completely agree with you that slack in public health systems is what we need more than anything. But I also wonder whether you think there might be a gap in how we build from medical expertise to public health expertise in surveillance. So increasingly we have multiplex tools for understanding the landscape of immunity in populations, which defines how pathogens can spread and what slows them down, which we can get from a drop of blood, so we could get this global immunological observatory. Should that not be something we should be thinking about investing towards to understand where the risks are emerging from?
Yeah, so your questions are excellent. So again, I think we've got to get away from this attitude, if we give vaccines to low-income countries, that's a nice thing to do, and it's a charitable thing. I think that's the wrong attitude. I think the more informed way is this is in our best self-interest. If we don't invest everywhere, we're going to put ourselves at risk again because we're just allowing more mutants to, viruses live to mutate and mutate to live. That's a line I've used a lot in my interviews. You're welcome to steal it. As long as we have, 2/3 of the world not fully vaccinated, these viruses will grow and mutate and change, and then it's going to come back in here. We're looking at this new Delta Plus variant in the UK and the US with some concern. I mean, is that going to be the next thing? I don't know about you, but when I see these rates here in Germany, I'm thinking, what's driving this? So the response, the answer has got to be a global response, not just because it's a nice thing to do, but because it's all in our self-interest. And then your point about surveillance is very, very important. I mean, again, back to the variants, we didn't track the variants very well in the U.S. because we just didn't have the money or the commitment or the systems for it. So even tracking, as Dan said in his opening comments, any number you hear has a wide confidence interval because we just haven't had these data systems that we've invested in. So we got a lot of work to do. Having said that, look at how far we've come in 22 months in terms of the data and the graphs and the vaccine development, which is pretty stunning. So there's a lot to celebrate, but then a lot more to do.
I just want to remind those who are watching this on Zoom that the Q&A column is open and at the moment underpopulated. So please do feel free to send in those questions. Okay, hands, please. Christine.
In the two-question tradition, first, where do you come out on the intellectual property? I'm not going to let you get away without offering us a view on that. Most of the research, of course, has been financed by governments, so you don't need intellectual property rights to let pharmaceutical companies earn profits to reinvest in research. But arguably, anyway, I'd be interested in your view on that. And the second question is, can you say something about what I call social media hygiene and how better social media hygiene could play into your framework of public information and, misinformation and addressing vaccine hesitance or rejection.
Yeah.
Thank you.
Well, two excellent questions. On your first one, we had a very interesting dinner conversation on that precise issue. Yeah, I think the broad question is how do we get vaccines more quickly and more equitably to deserving populations and who may not have the resources that high-income groups have? And would waiving intellectual property rights be one way to do that? And we could have a lot of debate on that. The president came out in favor of that to the surprise of many, but others in the pharmaceutical industry would say, okay, you can waive those, but that does not enhance accelerated delivery because there's so many other things you need other than the ingredients. Looking at my colleague who engaged me in this conversation at dinner, that you need the capacity, you need quality control, you need workers and scientific expertise, and all that takes a lot more than waiving intellectual property rights. So we're waiting for the World Trade Organization to weigh in, and I think in the meantime we need efforts like COVAX to be improved. And again, I respect them so much. The fact that they stepped up and said, okay, we're going to try to do this, I think is admirable. And there's no doubt there's been a lot of challenges, and you face a lot of them in Europe. The social media question, that has been a very disturbing part of this pandemic worldwide. And it troubles me when the social media heads are not stepping up and taking responsibility here. And they say, okay, well, we've taken off X million unscientific comments or whatever. It's clearly not enough. It's clearly not enough. And when the facts are so clear, when we have such great vaccines, not just good, but great vaccines, I mean, that should not be a matter of debate about whether they help people and save lives. But some people still resist because and the safety profiles have been excellent. I mean, the new FDA CDC recommendations for kids 5 to 11, I mean, the side effect profile was outstanding. So, I mean, that's something we should celebrate now, and social media should help promote scientific understanding, not complicate it.
Karen.
So I'm going to ask one question. Someone who's been involved in public health for someone who's been involved in public health for a long time, I'm wondering how you think about the short game versus the long game. You know, there's a saying, never let a good crisis go to waste. And there's so many ways in which one could use COVID to really advance our infrastructure for global infrastructure of public health. If I think about giving away vaccines that are about to expire or actually having a system that distributes vaccine, whether I think about intellectual property, notwithstanding that we have the difficulty of disseminating the vaccine, you could make progress on a COVAX kind of intellectual property system. How do you think, you've dealt with so many crises, about the short-term, long-term payoff?
Yeah, excellent question. So again, I think we've made progress. Look at the to have 7 or 8 billion doses already administered worldwide. I mean, who would have predicted that? That's stunning, right? When you see in your communities, local communities, doing these mass clinics in football stadia, and it's just thousands of people going through in a very efficient. That's public health success, right? That's prevention that's successful. And if you look at the glass half full, at least everybody's heard the term public health now. We don't have the problem that no one has heard of it. The challenge, though, is are they going to support it? And are they going to fight for it and invest in it so we don't go through this again? That's what I want to see. So, yes, we've definitely made progress. We can build on that progress, but we've got to do more. Because the gift of health is so precious. You know, we need people to enjoy their highest attainable standard and have complete well-being, and we're obviously not anywhere close to that right now, right?
Yeah. I would like to come back to one of our earlier questions that Dan raised, and that was, how do we prevent COVID-25, COVID-28,
Yep.
COVID-30? And I think what this reminds us of is the fact that all the major threats of humankind have been through infectious diseases. We forgot that for a long time.
Yep.
And I think at present we have very little knowledge of how these viruses spread, how new viruses move from one species to another, to humans.
Right.
So I was actually surprised to see that in the WHO concepts that you mentioned, One Health does not play a role. Research into the spread and generation of new viruses, other possible infectious diseases that may be on the horizon.
Yep.
I wonder what your view on that was and what we should do to foster that kind of research.
That's an outstanding question. So the scientific consensus is that a lot of these threats come from so-called zoonotic diseases. They start in animals, they go through an intermediary, and then they affect humans. So SARS, the consensus is it went from a bat to a civet cat to human. For MERS, it went from a bat to probably a camel to a human. And now speculation for COVID from a bat, which is a frequent reservoir, to perhaps a pangolin, question mark, to a human. But then the other overriding theory is that there was some issue in a laboratory in Wuhan. So, and the fact, this is the sad part, the fact that WHO sent their investigative team 8 months later to take a look and came back without a conclusion leaves us fearful that we will never know. But your point is absolutely, I mean, if it follows the same pattern as SARS and MERS, it probably was a zoonotic infection. And so how do we prevent those so-called zoonotic spillovers? That's a major, major question. So that's the ultimate prevention question for us going forward. So thank you for raising that.
Actually, that dovetails well with our first question in the Q&A, which I'll rephrase a little since you've touched on it. But how plausible do you find the lab release scenario? Exactly, with change of function, experimentation, so on and so forth.
Yeah. Well, could it have... The consensus is, and so I'm not sure I'm the expert to... Let me just put it this way. Since no one really knows, no one can say for sure, many are concerned that this was another zoonotic transmission. There are some concern that it may have come from a laboratory source in Wuhan. Did it come specifically from so-called gain-of-function research? That appears not to be the case. And if I can say, Dr. Fauci and Dr. Collins have said strenuously that is not the case. But could it still have come from a lab? Apparently that is still an optional, a potential way this could have all begun, which has not been ruled out. My fear, Dan, is will we ever end up saying for sure? I don't know if we're going to the rate we're going. That's what concerns me.
So one quick follow-up then. Given the plausibility of the thesis, if not its provability, what does that tell you about global efforts to prevent bioweapons development?
Yeah. Well, again, people want the most cutting-edge research, but then when something like this happens, they're very quick to look back and point at fingers, which, again, I think the speculation here concerns me deeply. We don't have any proof of where this came from. So all we can say is what we've just said now here for the last couple of minutes. There are a couple options, and no one really knows. So that's. And meanwhile, I think research has got to go forward because people will demand cutting edge research. Otherwise, they feel like science is not protecting us the best way it could.
Okay, Betrayal.
So this has to do with, it's pretty much grounded in the American experience, but it may affect things that have happened in Europe. The public health strategy with respect to communication and communicating in the context of uncertainty and evolution and science. I just remember an episode with respect to Dr. Sanjay Gupta on CNN early in the pandemic, and he was dissuading people from using masks because at the time it was thought that it was droplets and masks, wouldn't help and potentially would have harm because you would touch your face. That would increase the potential risk for yourself. There's also the desire to save masks for medical professionals who are dealing with it up front. And of course that turns out to be a mistake, but not a mistake because it was intentional misinformation. It was just lack of information and evolving science. But what worried me about that particular episode and what may contribute to hesitation and resistance is the degree of definitiveness with which this advice was given, right? And the idea that you come back later and say, well, science is uncertain, it's evolving, right? And we've learned more. To the public, you've told us one thing in a definitive way, and now you're coming back and attributing it properly to science's evolution. But the way things are talked about can be important. And so I've always wondered in terms of what is the counter to humility, in terms of, well, science evolved, this is what we think could happen. But then I worry that people aren't going to take it seriously if you approach it with humility and modesty and admit the lack of full information on it. So how do you overcome this public health communication strategy dilemma?
Yeah, what an outstanding question. That is the art of public health leadership and communication, because in crises like this, or anthrax, what I went through, and H1N1 and Zika and Ebola, information is changing and coming at you by the day. And then in the ideal scientific world, the scientists will relate to that, you do research, and you submit to a peer-reviewed journal, and you wait for it to be published and peer-reviewed, and then you announce the policy recommendations. In a time like this, you can't do that. I can't get over how many results are reported by the press first based on somebody's press release or some submitted article that hasn't been peer-reviewed that's on a preprint server. But you know what? We're in a time where the officials have got to take what they got and go with the best choice they possibly can, knowing that it's not definitive science. So then you throw into what you just said, say this is, so maybe the best way I can answer, you say, this is what we know now. This is the best recommendations that we have based on what we have. This may change, and if it does, we'll come back to you. And if you're honest about that and you build trust, hopefully people will stay with you when you have to go back and change it. But 22 months into this, where every public health professional has had to change, it is really tough. This is why the public worldwide is getting pretty frustrated. So this is the art that I think all public health leaders have got to grapple with and live with. And then when they get criticized, you just say, hey, I just did the best I could with the best science I knew. No one's going to be perfect here. I'm going to add that all up. I'm going to say I think Sanjay Gupta is really an excellent communicator. I respect it. And I think Tony Fauci is outstanding. And both of them have been criticized because this is such a complex threat. But your point is excellent, so thank you very much for raising it.
You have a question? Yep. Okay. Because I saw your hand was up and I didn't get you. Do we have a microphone, please, up here? Yeah.
So, thanks for your excellent talk.
Thank you.
You mentioned it that the pandemic can only be beaten by ample or broad vaccination, and I think we're making good progress. When we're looking back, you said it yourself, within 12 months, we came from basically dosing from the idea to actually approving a vaccine that was safe and effective.
Yep.
Moving away from COVID and into learnings for public health, when today people get killed more so by other diseases like cardiovascular disease, cancer, or other things, and bringing a novel medicine to patients to treat heart failure or other cardiovascular diseases, it will take typically 6 to 7 years from the idea to actually bringing it to a broad array of patients. Or when you think about treating cancer, it will take 3 to 4 years before you will get a product ultimately to patients. What can we learn from the speed and this unprecedented collaboration that we saw between the public sector and the private sector to actually solve a pressing health issue? What can we learn for other diseases?
Great question. So I only quickly touched on so-called Operation Warp Speed, which was a Trump administration initiative, and that phrase has been sunsetted in the new administration. But just to refresh everybody's memory, the United States and HHS and NIH put in, I think, about $12 billion up front and gave it to 6 pharmaceutical companies and said, here, we're going to give you, I think somewhere between $1 billion and $2 billion each up front, so you can fund your R&D for a new COVID vaccine. I remember at the time hearing that number and thinking, oh boy, that's a lot of money. But when you think that upfront public-private commitment last year is what got us to where we are now with the vaccines, it was an incredible investment. I know Dr. Fauci and Dr. Collins, who I worked with, both were very involved in that proactive strategy. So are there other examples where there can be sort of public-private commitments up front to do R&D, and then when the products are found to be safe and effective, again, some agreement about how, cost savings and buying up these doses and then trying to distribute it in places in need? Can that model work? Stefan, you probably know more about this than I do, but I think this is where that public-private partnership and that investment last year was fantastic. And as a scientist, and a public health professional, I applaud that.
What was different between Warp Speed and, say, the war on cancer, which we had for years and years, and all the funding that went there? Yeah.
I don't know. Maybe there are others who would help me on this. For Warp Speed, it was an explicit agreement. We're going to give you, $1 billion to $2 billion per company. But if you get something that's safe and effective and it gets authorized or approved by the FDA, then you got to agree to work with us to make these available at a lower cost. And I don't know if
maybe the war on cancer was just more primary research. Yes.
Yeah. I don't know if that model. Okay.
Okay. Last questions. Mr. McGillis.
Dr. Koh, one thing I appreciated so much in the talk was that you mentioned all these other terrible trends the last year or two and other consequences of this terrible period, including rise in opioid deaths, the decline in mental health, people not seeking care for other serious conditions, so rise in mortality for those things. I would add to that the couple others, the rise in gun violence in the U.S. this last year, which I think was definitely, wrote a piece about that being tied probably to the pandemic, and also the decline in vaccinations in developing countries, that it's very worrying. And then finally, the lasting costs of the school closures and the years-long consequences that are going to flow from that. And I guess I just wonder, from a public health perspective, and public health is all about taking in the broader picture and all the costs, the whole landscape. Did the profession and policymakers somewhat lose sight of some of these other costs and become overly fixated on this threat, albeit as terrible a threat as it was? And if so, how can we kind of now, in a post-vaccination world, kind of move into a different realm where we're taking some of these other things into greater account as we're making our policies?
Excellent question. What an excellent last question. Can't you tell he's a reporter? Yeah, in our society, in health and elsewhere, we often get fixated on, the most pressing thing at the time, and then we sort of forget about everything else. That's what's happened through COVID. I mean, we've been so appropriately consumed by COVID that we've forgotten about all these other threats that come at us every day, and Alec just rattled them all off, So we've lost ground on all of it. And that's why life expectancy last year went down by, up to almost 4 years in, some communities of color. I mean, it's just terrible. So we got to regain ground on all that and do it all together. And now we have climate change too, by the way. So this sounds daunting, and it is, but we've seen the folly of just focusing on one thing and forgetting about everything else. If I can say, since I've been in public health departments for the last 20 years, I know that at HHS right now and in state health departments, they're all doing pretty much exclusively COVID, and people doing other things have been pulled away. And we understand that for a while, but you got to take care. You got to take care of all of it, because if you add it all up, people are losing days where they could be enjoying their families and enjoying the gift of health. And we've not had a balanced, broad commitment to prevention and policy in all these areas. So that's where we've got to go going forward. And if everybody here can commit to that, I mean, that hopefully could be another lesson learned from all this. So thank you so much for raising that.
Okay, well, a great note to end on. I want to thank you,
Dan.
Howard Koh. It was fantastic to have you here and to get the benefit of your wisdom on these very large issues. I also want to thank BioRIG for its tremendous support that made this event possible. Our next event will be tomorrow, November 4th, when we will move from a real and troubling world to a fictive world, which we will find out how troubling it is, as we hear from our Mary Ellen von der Heyden Fellow, Lan Samantha Chang, who will discuss her forthcoming novel, The Family Chow, which follows members of a Chinese diaspora family and follows their experience of long-term assimilation into mainstream American culture. If you want to register for that event, please do go to our website. We hope we will see you then, and if not then, soon back here at the American Academy. So thank you very much, and thank you very much for joining us.
Okay.